final formal speaker is Dr. Fernando Sipman from Madrid, Spain, to talk to us about alveolar and airway collapse, preventive measures by best PEEP titration.
Thank you. Using knowledge about the mechanism involved in ventilation based on injury has shifted our approach of titrating PEEP in patients under mechanical ventilation. If we think about an ideal condition of ventilation of patient, we can think about a situation like this, when we have the airway pressure on the y-axis, and we can define an optimal window of pressures in which we can apply or identify a PEEP level that is avoiding collapse of the dependent lung regions, no mechanism of ventilating lung injury, and a pressure gradient that is avoiding or minimizing the overextension of the upper regions, the already average regions of the lung. To achieve this optimal condition, we need to go through two important steps. First, we need to recruit the collapsed tissue, and second, we need to identify the PEEP level that is achieving this compromise between preventing collapse and avoiding overextension of the lung.
Reality looks a little bit different, and this is a nice study done by Esteban, published in the Blue Journal a year ago, in which they tried to study how mechanical ventilation was applied in a number of ICUs. More than 400 ICUs were included, and among many interesting findings, they could see that almost 80% of the patients were ventilated with PEEP levels below 5. When discussing this result, they came to the conclusion that this low level of PEEP was applied without any strategy, any concept, and it was more a specific directed order on the medical charts. So the importance of having a concept when applying PEEP can be illustrated in an example like this. Everyone, or the current approach to PEEP titration in clinic is to look for the PEEP level that is achieving the best oxygenation with the lowest possible FiO2. In this graph we're showing incremental PEEP levels and oxygenation, and I think many of you are used to this type of approach of titrating PEEP. What we do is starting from 5, and we're ventilating a sick patient with ARDS with a tidal volume of 6 mL per kilogram. We start with 5 centimeters water of PEEP, and we stay at this level for 4 minutes and looking at oxygenation. Then we make a bigger step because we were not happy about this oxygenation, 5 centimeters of water. The oxygenation decreased a little bit, and then we increased in 2 centimeters of water steps and looked at the oxygenation. Well, looking at the increase in oxygenation, we probably would be happy in a level but about 14 to 16, and we will set our PEEP level on that level finally. Then we further challenged the lung. We thought maybe if we increase PEEP a little bit more to 25, we're able to gain some tissue for gas exchange, and our oxygenation will improve. What happened with increasing to 25, nothing happened with oxygenation. We almost stayed at the same level. And then we applied the concept. We thought maybe this patient has an important amount of collapse, and maybe we're able to recover it. So we applied a recruitment maneuver consisting of increasing pressure to 55 centimeters of water, PEEP of 30 for 2 minutes. Then we turned back to a PEEP level of 20, and our oxygenation just boosted up to almost double the value we had at the beginning with a PEEP level of 20. And then we start to titrate our PEEP level in a descending way. In 2 steps, 18, 16, 14, until 12, where we saw that our oxygenation was again decreasing, being a clear indicator that we went too far low with PEEP and that our lung was starting to collapse. Well, from theory to praxis, it is difficult at the bedside to follow the dynamics of recruitment and lung collapse. So there's no specific monitor that helps us or guide us through all these procedures. And we are evaluating the Open Lung tool, which is a software developed by Siemens integrated in the multi-parameter monitor. And what they mainly do is to follow on a breath-to-breath basis the evolution of pressures, the plateau pressures, the PEEP levels, and the dynamic compliance. Specifically, we're trying to study the ability of dynamic compliance of detecting or describing the process of recruitment, and especially detecting the collapse of lung. Then we are validating the study of dynamic compliance by looking at the lung from different perspectives through all this dynamic process of recruitment with the CO2 dynamics, what happens with the hemodynamics, and especially compared with what is considered now the best tool available to follow clinically the recruitment procedures, which is the online blood gas. Then we had a chance to integrate all this information in a lab software, in a laptop, and then have an offline analysis of our data. The concept of using compliance to try to titrate PEEP is not new. Actually, this is a publication from 1975 from Sutter and colleagues, a very famous publication in the New England Journal of Medicine, where they defined the best PEEP really using a concept. They looked for the PEEP level that was producing or allowing the best value of oxygen transport to the tissue, and they found out when comparing this PEEP level with other parameters that it was coincident with the best point of compliance in these patients. But by only having an increase in pressure, that is only looking at the inflation limb or of the pressure-volume relation, they missed a lot of information. This has been nicely shown by a recent published article by Hickling in the American Review of Respiratory Care Medicine, in which he, on a mathematical model, he systematically studied the behavior of the tidal PV slope, that is compliance, during a incremental PEEP trial, that is along the inflation limb of the pressure-volume relationship, and compare it with a decremental PEEP trial, that is on the deflation limb of the volume-pressure relationship after inflation, that is after a recruit maneuver. What he found was that when analyzing complying on this part of the relation, it was very difficult to extract valuable information. Compliance was very much dependent on processes such as ongoing recruitment and overdistension, and there were no correlation between the compliance in this part of the relation and the occurrence of lung collapse. But when going back on the deflation limb, he saw that for every level of PEEP, the tidal PV slope, that is compliance, was much higher on the deflation limb when compared to the inflation limb. Moreover, he saw that the slopes were actually drawing the line of the deflation limb of the volume-pressure relationship, and the loss of compliance during this trial, this decremental trial, was related to the ongoing process of lung collapse. This is more graphically shown on a beautiful CT scans that was kindly provided by Dr. Amato and Dr. Borges from São Paulo, Brazil. Here we're showing a complete pressure volume curve, the inflation part and the deflation part, and I chose the pressure point, the same pressure point on the inflation limb and on the deflation limb. The point on the inflation limb, which you can see is a little bit above the so-called inflection point, is showing a huge amount of collapse, and I must remind you that this has always been said to reflect the PEEP level that is preventing collapse to occur in the patient's lungs. But the amount of collapse is just amazing. The same pressure point, but on the deflation limb of the relation, is showing a much better aerated lung, and I think the images speak for themselves. We're ventilating the lung in a much better volume-pressure relationship at this site. So going back our protocol in the evaluation of the open lung tool, this was the protocol we used in the different patients included in the study. In this graph, we are showing the pressures and the dynamic compliance in the left y-axis, oxygenation measured continuously on the right y-axis, and all this on a time scale. In yellow, we have the different PEEP levels. In orange, the plateau pressures applied. In white, we have the changes in dynamic compliance. These are the 3 parameters included in the open lung tool. And all this was compared with the oxygenation depicted in blue. So what we first did was a recruit maneuver. In this case, we went up to a pressure of 50 with a PEEP level of about 18. The result was immediately seen with increase in oxygenation and an decrease in compliance when reduced pressures. And then we looked at the descendant or decreasing PEEP trial, which is the same as looking at the deflation limb of the volume pressure relationship. And we were looking for the closing pressure point. And this point was defined in two ways. According to oxygenation, which meant a decrease in 10% of the maximum oxygenation obtained after recruitment, and with compliance was the reduction of compliance after acquiring a maximum volume after recruitment. Then we went down to 0 of PEEP, looking at the evolution of oxygenation and compliance. We made a new recruit maneuver with the known pressures at the beginning, and then we tried to test if this closing pressure detected was accurately enough detected to prevent collapse or to maintain oxygenation and compliance after the second recruitment, exactly at this level. So when looking at the results in more detail, we included two groups of patients. One group that we considered healthy patients with no major lung pathology or disease, but a tendency to collapse. And this group was mainly represented by cardiac surgery patients, and another group of more severe disease patients, acute lung injury patients. So if we looked at the results in terms of compliance, which are depicted in white, and oxygenation on each single decremental PEEP level, again, oxygenation on the left side, compliance on the right, we were able to identify the typical pattern after a successful recruitment. That was an initial increase until a maximum value was reached, and then continuous decrease of compliance values, unequivocally indicating lung collapse. Then compared with oxygenation, we showed mostly the same behavior with initial increase. These increases probably indicating relief of overdistension as PEEP levels were reduced, and getting to a maximum point, and finally reducing the values, also indicating lung collapse. We also were able to identify the individual patterns, and for instance, try to, looking at the pattern of the curves, try to see if we were able to perform a successful recruit maneuver, or if our PEEP level chosen at the beginning was high enough. So whenever we saw this pattern, that is a continuous reduction, even if starting from high levels of PEEP, a continuous reduction in oxygenation and in compliance is always meant one of these two possibilities. Or we didn't reach the opening pressures of that specific lung, or the PEEP level chosen for starting the trial was not high enough. So when looking at the results, or the preliminary results of the different patient groups, here these are the mean values for every PEEP level of 10 patients who were studied after cardiac surgery. The protocol I just showed you was performed, and then we made the decremental PEEP trial. And you see that it's almost a perfect matching between dynamic compliance and oxygenation. Moreover, the point of maximum compliance was even achieved a little bit earlier than the maximum point of oxygenation, suggesting that in this group of patients, even dynamic compliance could be an early indicator of lung collapse than oxygenation. And another interesting finding is that the PEEP that we had to apply to stabilize the lung, even in these healthy patients, was higher than we initially expected. It was about 10 to 12 centimeters of water. A different picture is the one we obtained with acute lung injured patients. In these patients, oxygenation is a much earlier indicator of lung collapse. We much earlier acquired the maximum value, whereas compliance is a later indicator, but showing the same pattern. But importantly, in compliance, we had a clear cutoff point, a clearly point where we could identify that this was the absolute limit for PEEP application. If we went further down, the ongoing process of massive collapse was not able to be stopped. So we should have to recruit again the lung. So Between the collapse point defined by oxygenation and the collapse point defined by dynamic compliance, it will be able to try to find out a margin of safety for the application of a PEEP value that prevents this ongoing collapse process. When analyzing differently this data, we made the same type of analysis that Sutter made on his paper, and then we identified, according to dynamic compliance, the best point or the best PEEP according to the best compliance, and we saw that in this group of patients with no lung problems, only collapse, this was matching with the best point in oxygenation. A different result, again, in acute lung injured patients, where we could see a clear cutoff point again in compliance, but this had no relation to the best point in oxygenation. So the use of compliance for protective PEEP titration requires the following prerequisites. First, we have to optimally recruit the lung, get rid of all the atelectatic tissue, and then go on with a PEEP reduction trial using low tidal volumes. This is important because using high tidal volumes, and I didn't mention this when I was showing the protocol, it was done with 4 mL per kilogram. Using higher tidal volumes, as I was saying, is leading to a phenomenon of tidal recruitment that probably is blurring or is giving more problems or troubles for the interpretation of the compliance signal. The information we can get from the dynamic compliance is that we are able to recognize adequate recruitment, and we can recognize lung collapse. We can have a description of different patterns, of different patients, of different degrees of lung severity, and importantly, we are able to identify a threshold PEEP level below which we know that collapse is occurring, so we can take the maximum advantage of a recruit maneuver because we identify the PEEP level at which we have to keep our pressures above it in order to avoid collapse. Of course, there are a number of limitations. The major one is that we're only obtaining global lung information. We don't know what's happening regionally with PEEP levels, if we're overextending some regions, or if others are starting to collapse. Another limitation is that the sicker the lung gets, we have an underestimation of the closing pressure only using compliance because we have an increasingly heterogeneous lung. There's an unresolved conflict between collapse and overdistension when analyzing the Senate trial of PEEP titration and dynamic compliance measurement. And there's a need for a definition of a margin of safety for PEEP in those patients where dynamic compliance is not matching with oxygenation. The definition of a lung protective PEEP titration would be the PEEP level that prevents an expiratory collapse, obtained only with a stepwise reduction after optimal lung recruitment, but the real benefit is integrating this PEEP level in a rational protective ventilation strategy, limiting other known factors that are causing ventilation-induced lung injury. Still, the open question is, what is worse? Can we afford a little bit of overextension, being very not trying to have any collapse in the lung, or can we allow a little bit of collapse and not taking so much importance about overdistension? So this remains an open question. And this is a little game I made with the first slide or the second slide in my presentation from the work from Esteban. I just used the mirror function of the computer. And if we're thinking of titrating PEEP not only to support ventilation or to improve our oxygenation, but integrating in a lung protective strategy, we really should seriously think about applying higher levels of PEEP to our patients. Thank you very much.